Hey, we're back online. This is MS Warrior podcast. I'm chatting to Laura, Nicola, I got Alison and Dr. Ruiz. So, and we're going to talk about all things HSCT, especially in Mexico. So yeah, Alison, if you'd like to take over and go from there, please.
Okay, so we have spoken to Dr. Ruiz before. We have an interview with Dr. Ruiz on our website, aimscharity.org. But something's happened in the last couple of weeks that really made us want to do this particular interview. So what happened was a patient who was looking into HSCT had contacted us and also a neurologist. And the response that she got from the neurologist had a lot of incorrect information about Mexico and what happens in Mexico. And the problem was that this was a neurologist who is involved in HSCT, who is at one of the London hospitals. And we thought, well, my goodness, if this is somebody that is involved in it and knows about it, who's very knowledgeable, then this is a problem, because we know that so many neurologists in the UK really don't know anything about it at all, other than what they're told at conferences and so on. So we thought we really need to nip this in the bud and correct this misinformation, because this is something that's been going on for a long time. This is not the first time we've heard something like this. So we reached out to the HSCT community and we asked them to submit their questions and statements that their neurologists or doctors or other people have made to them about Mexico that we know to be untrue, so that we could put them to Dr. Ruiz. So the first I really wanted to cover before we sort of get into the questions is the fact that Dr. Ruiz is a fellow of the Royal College of Physicians in London, because we want this right video. We're hoping this video will be shared with patients, doctors and neurologists and so on. So we really want you to know the credentials of this man. So Dr. Ruiz, can you tell us a little bit about that?
Well, yes, I was trained in Mexico, but I am a fellow of the Royal College of Physicians and Surgeons of Glasgow, also a fellow of the Royal College of Physicians of London. I am a master of the American College of Physicians, and I recently got a honorary degree by the Universidad Autónoma de San Luis Potosi in Mexico.
Incredible. So, yeah,
qualified.
People to know that that this is somebody with incredible experience, who is a lot more qualified and has more accolades than many of our doctors in the UK as well. So now we're going to move on to the questions and the statements that we have heard from people over the last few years about Mexico. So I'm going to hand over to Laura.
Thank you very much. Hello, Dr. Ruiz. I'm going to start with a statement and then ask the question from the back of that, if that's okay. So the statement that we are looking at is, it's not proper chemotherapy in Mexico, it's HSCT light. The UK mobilisation criteria is 4 grams of cyclophosphamide per square metre of skin surface. And the UK transplant protocol is 200 milligrams of cyclophosphamide per kilo over 4 days. So the question that we would like to ask is, how much chemo per kilo is given in Mexico?
It's exactly the same. That is 200 milligrams cyclophosphamide per kilo over 4 days. The only difference is that we use it in 2 days, and then we stop the chemo for 7 days, and then we give 2 additional days, making up a total of 200 milligrams per kilo. So it is exactly the same. By splitting the doses in 2 blocks apart, we have shown and published that the toxicity to the bone marrow, to the kidney, and to the heart is substantially diminished.
Thank you for confirming. And I'm going to pass back to Alison, please, for the next question.
Okay, so yes, and another statement that we hear regularly in the UK is that HSCT only works when there are active lesions. And in fact, this is part of the criteria in the UK. In Sheffield, they will treat if there are active lesions. In London, they will treat if there is either one active lesion or two new T2 lesions compared to a scan within the last 12 months. So what do you say about this idea that it only works when there are active lesions?
Well, we have shown and published, as I already said, our experience grafting patients with all type of multiple sclerosis, and we have shown that despite the fact that those with relapsing remitting are the ones that have a better response, you also get a response in other forms of multiple sclerosis and also in forms of multiple sclerosis without active lesions.
Excellent. Okay, I'm going to pass over to Nick now.
Hello. Well, I am someone who has had HSCT in Mexico. I have been back a month and 8 days, and hence the lack of hair. My question is, which I already know is untrue, but I would like you to confirm it. The hospitals in Mexico are filthy. They have dirty floors. You're sent home in a filthy taxi.
Well, that is not true. Hospitals in Mexico are similar to the ones that you get in any part of the world. In addition to this, I have to tell you that we do not use hospitals for doing the transplant, so that's irrelevant. And in addition, also, I can say that we have special vehicles to bring the patients from the airport to the premises in which they are grafted. So this is totally misleading.
It is, and can I just add, having been there, when I had my stem cells harvested, that was the only time I went to a hospital, and I was the only person in there. I went to a separate ward. I was the only person in there on my own, no one else around. I also, yes, the taxis are not brand new, but they sanitize everything. As soon as you get in there, they picked me up from the hospital. He sanitized his hand, he sanitized all our suitcase, he sprayed us. Everything was so clean. It just wasn't a brand new taxi. And I went to the chemo in a private room on my own that was all sanitized. And my apartment, I had a lady who came and cleaned it every single day and changed the sheets every single day. So that is a complete myth from someone who's been there. Okay, Alison, your question.
Okay, so the next question really relates to the protocol that's used. Now, in the UK, the protocol that's used is cyclophosphamide, which we've already established is the same quantity. But the adjunct that they use in the UK is RATG. And what we hear quite regularly is that rituximab, which is the adjunct that's used in Mexico and in Russia as well, is not as effective as RATG. What can you tell us about that?
Well, we have shown and published our results, and our results are very similar to those obtained with the same amount of cyclophosphamide and ATG instead of rituximab. So rituximab is substantially less toxic than ATG, this being the reason why we chose it instead of ATG.
Yeah, okay. Laura.
Thank you very much. Dr. Ruiz, here is a statement that we have received from a disparaging neurologist that we will not name. And the statement is, NonMilo isn't as effective as myeloablative. Non-Milo versus Milo. What are your thoughts on this?
Well, it has been shown not only by us, but by other centers, that non-myeloablative is about as effective as myeloablative. One of the salient differences is that the toxicity of non-myeloablative is substantially less than the toxicity of myeloablative. This is very, very important to conduct the stem cell transplant program. In our experience, we have had only 2 fatalities in a total of 1,134 patients with multiple sclerosis, which we have grafted up to now. this rate being probably the figure that indicates the toxicity of our procedure, which is one of the lowest one in the world. But as I said, the effectiveness is the same.
Thank you very much for clarifying for us. And I'd like to hand over to Nick, please.
Okay, my question from someone is, you don't even know that they're giving you your stem cells back. So what would you say to that?
Well, it is interesting, that question. Of course, we use the machine to pull out the stem cells. We very carefully enumerate the number of stem cells. We transplant the patients with at least 2 million cells per kilo. But as a matter of fact, the median of stem cells that we are giving the patients is about 7.6 million per kilo. So that's enough, and our records are there to be inspected if necessary. Now, all this information has been published in several journals, peer-reviewed journals. It is not what I say, but it has been already published. And our protocol is registered in the clinical trials website of the National Institutes of Health in the United States. And all that information is available in those websites.
Excellent. And we have links to all of that research and to that peer-reviewed research as well. So we will be sharing that on our website so people can refer directly to that.
Can I just add to that as well, that I find that question quite offensive, actually, that how do you know that they're giving you your stem cells back? I've been to Mexico. The nurses, the doctors are so professional, and I can't believe that someone would think that they wouldn't give you your stem cells back. My name was on everything with my date of birth. The nurse, the doctors, they made me check everything and sign to say that I was receiving my bloods back. I just find that really offensive, that people think that because we're in the UK and you're traveling abroad or wherever you happen to be, you're not going to get the same standard of care, because I have to say it was far surpassed.
Yeah, I think you're right, Nick. I think that it does seem that they are inferring that there is less professionalism somehow in Mexico than there might be in the UK. And we had a conversation about this yesterday, and you said, how do you know you're getting your stem cells back anywhere? You trust, because you trust them to be professional. And so I think this is where I would refer any doctors who are still in two minds about this. Again, what we've said about Dr. Ruiz and his credentials, which are there for anybody to check. You cannot dispute that, cannot dispute it. Mm-hmm. Okay, we had a question in regard to accreditation of the centres of the hospitals in the UK and in Europe. The hospitals that can carry this out for MS, they have to be JC registered. That's sort of the gold standard. That's what they're looking for. Somebody asked us if your hospitals are FACT registered, which I understand means it's the Foundation for Accreditation of Cellular Therapy, and they said that they understood that Monterrey is FACT accredited and that Puebla was on the way or something. What can you tell us about that?
Well, FACT and JC, as you know, have joined recently, and they are in charge of making the accreditation of transplant centers all over the world. I am a member of the International Committee of the FACT-JC organization, and the facility in Monterrey is by now already accredited by FACT-JC, and we are in the process of having this accreditation. We have been inspected by them, and we are waiting for the final determination about our accreditation.
That is amazing news, and I think that is going to stop a lot of this in tracks, because JC is sort of something that they waive to stop people from going overseas, and knowing that there is that link between the two is fantastic. That's really very exciting. Okay, so I'm now going to pass over to Laura.
you. I think you've probably answered most of this already, Dr. Ruiz, but the statement here that I'm going to put to you is the stem cells need to be frozen, but Mexico don't do that. What is your response?
Well, we have been working on grafting non-frozen cells for about 20 years by now. We were the first in the world to do this and to prove that they work if you keep them in a conventional refrigerator for up to 5 days. So based on that experience that has been published widely, we decided not to freeze the cells. And by avoiding freezing the cells, you gain viability of the cells, you shorten the period of neutropenia and thrombocytopenia, and you improve the results. In addition to this, you cut substantially down the expenses of the procedure. So this is something that was started by us very many years ago, dealing mainly with patients with hematological malignancies. And nowadays, most centers all over the world are avoiding grafting. I mean, grafting is something of the, freezing is something of the past in the practice of HSCT. But there are people that still are doing that.
Thank you. I'll now hand over to Nick, please.
I have to say, I came out of neutropenia within a week of being home. It was so fast for me to come out of it. Other people haven't been as fast, but I went into it very, very healthy anyway. I don't know if that makes any difference, but I came out of it so quickly. Okay, my question is, and I don't know the answer to this one because I'm so new to it. Someone has said they don't follow up with all their patients. Is this true, or is this?
Well, we would like to keep the patients in Mexico for very many years to follow them, but this is obviously impossible. So we have a system, an electronic system, to find out how patients are doing, and this is how we have been able to register the responses to our method of conducting transplants. Interestingly, our response rate is around 70%, 70. We would like to have it in 100%, but this is not possible. 70 is not so bad, and we rely on the willingness of the patients which have been grafted by us to provide us with subsequent information about how they are doing. 70% of them respond to our request.
That's a pretty good response rate.
Yes, very good.
Or surveys or follow-up information. So that's actually very impressive.
Yeah. Now, yes, this question comes from the same neurologist that said that non-Milo is a waste of time and that Milo ablative is the only way to go, and we will make sure that he gets sight of this this podcast as well. So he said that Mexico will treat anyone if they have the money. There isn't any screening. They just want your money.
Well, that's not true. First of all, I would like to say that I respect the opinion of this person, but I do not agree with him. Second, I would like to say that there's a screening procedure prior to the patients coming to Mexico that we do by electronic media. And then when the patients arrive here, we do additional screening. We screen them for COVID-19 infection and for some other diseases, heart diseases, lung diseases, kidney diseases, and so on. We have been able to reject the transplant in several patients in which we have found, for example, a malignant lymphoma, active tuberculosis, an active COVID-19 infection, and so on. So we do screen after screening by electronic media. We do not reject patients on the basis of the type of multiple sclerosis that they have, but we do screen for some other diseases that preclude the proper conduction of stem cell transplant.
Can I just tell you how much they screen? Because I get cold sores, and they did some tests on me. My MRI from the UK wasn't strong enough, so I had to have a massive MRI before I left. However, 3 months before I went, I had to send them all of my details, everything, so that they could check my MS and where it was at. My most recent MRI that I had in this country, when I sent it across, they said that's not good enough. It doesn't show enough. You're going to have an MRI when you get here, which I did, a 4-hour one. Thank you very much. And then they took my bloods, they tested me for stuff, and it came up that my cold sores were active at the time. So I had to go and have another blood test to see whether it would cause any problems to have the procedure. So they really, really test. And, I'm not trying to encourage people to go and have this done. I'm just saying I had it done. I witnessed it. They really, really test you. And I was panicking that I wouldn't be able to have the procedure done purely because I had active cold sores in there, but it was fine. They said, this is okay, we can do this. And they took my bloods to check how active it is. So they do.
Okay, the next question is coming from Laura, and this is one that comes up again and again and again from the neurologist, and we have already touched on it, but you can just expand on it a little bit more. You'll see what we mean.
Thank you very much. Yeah, the question is, do you have any peer-reviewed data?
Well, yes, all the patients that we have grafted have been published in journals that have peer review system. The Lancet, for example, is a very well-known medical journal in the Great Britain, and we have published our results in Lancet. We have published our results also in Acta Hematologica, in clinical transplantation, in bone marrow transplantation, several journals that do have this peer review procedure. Both Dr. Gomez and Maguer and myself are reviewers of these journals, and we do have some experience with that process of peer reviewing.
Thank you. May I just ask a follow-up question to that? Do you actually publish the numbers of people that are rejected for transplant, i.e. they don't meet the tests successfully that you run to make sure that it's actually safe for them to undergo the procedure?
We do have that information, but we have not published a paper on our rejection of persons for some or other reason. We can do that very easily, and most likely we will publish that information very soon. Our last paper published deals with the 1,000 patients transplanted in our centers. And in that particular paper, it is clear that 80% of the transplants have been done in Puebla and 20% of the transplants have been done in Monterrey with very similar results. And we have compared in that particular paper our experience with that of other centers transplanting patients with multiple sclerosis in Brazil, in the United States, in the United Kingdom, in Sweden, and some other places.
Thank you very much, because I think that would actually help support the answer to the question about Mexico just wants your money. Thank you very much. I'm going to hand over to Nick, please.
Okay, this question I'm going to split into two. Now, one of them I think is kind of a question you can't answer because it depends on each person, but the question is, how long will the roller coaster last? So after you've had the treatment done, you obviously then have a massive roller coaster where you will feel great some days and then your MS will feel worse. I'm going through the roller coaster at the moment. Now, is there any clue on how long that lasts?
Well, our 12-month response rate is around 80% in all type of multiple sclerosis. It's a little higher in relapsing remitting and a little lower in the progressive forms. That 80% includes 40% stabilization of the disease and 40% improvement of the disease, leaving only 20% of patients that do not have a response to the transplant. Of the ones that respond, which are 80%, some of them go through this rolling coaster effect. And as I said, at 12 months, our results are 80%, and at 18 months, they go up at around 85%. around 20% of patients do not have a response to the transplant. And this is the experience of other centers all over the world dealing with this type of disease.
The second question is kind of linked on to that is, do we know why people don't respond? And I know this is something Lee will probably want to know. Do you have any clue as to why people don't respond to it and it doesn't work?
We have analyzed some data, and there are two variables that are related to the non-responsiveness of the patients. The time of evolution of disease before the transplant is one. I mean, the longer the disease is there, the lower are the chances of responding to the transplant. And also depends on the type of multiple sclerosis that you have. If you have the progressive forms of multiple sclerosis, your chances of responding are lower than if you have relapsing remitting. But again, even in progressive forms, our response rate is between 65 and 70%. These figures are better than those obtained with any of the drugs that is used up to now in multiple sclerosis, such as natalizumab, ocrelizumab, rituximab, etc. These drugs render a response rate at best of 50%, 50. And with the transplant, these figures go up substantially, and that is substantially better. It has also been shown that the cost effectiveness of the procedure is better than that of the drugs that are employed to treat patients with the multiple sclerosis. Despite the fact that it's an expensive procedure, sometimes it's a one-time procedure, which contrasts with what you have to do using the novel drugs to treat these patients.
Totally agree.
Of course, and we've spoken about the fact that it's not just the cost of the drugs that mounts up, it's all of the peripheral expenses that come with a progressing disability, the hospital care that you might need outside of the drugs themselves. It's very expensive for society, so it seems false economy to be spending all the money on the drugs when this has a better outcome even for progressive MS.
Especially when you consider that I was given, we think there is an 85% chance of Tysabri slowing down the progression and calming down relapses versus a straight kind of 70% definite success rate for HSCT. They were the stats I personally looked at and decided that, you know, we think it might be 85%, but we're not entirely sure how it works, is way worse than we know you have a 70% chance of success.
Exactly. We in the UK, there is an upper age limit, which I believe is 65. Does that sound about right, Laura? I think it is 65.
I think the original criteria when I looked at it in 2016 was you had to be under 55 to meet the criteria. Yeah. Okay.
I think that they've changed it because I'm sure I will be pulled up on it if that's wrong. But I believe it's 65. Do you have an upper age limit? We have a lot of people saying, well, it's really not suitable for you if you're over 50. So what are your thoughts on that, Ruiz?
We have grafted patients up to the age of 65. It also depends on the comorbidity index. If the patients are 65 and they have in addition diabetes or renal failure or some problem, then we prefer not to do it. But if they are in good health, as far as the comorbidity is concerned, we can go ahead and do it, yes.
Okay. This is probably my favorite question that we were asked to ask you. We wondered, have you ever treated any neurologists with MS or autoimmune diseases?
Yes, we have treated a neurologist from the United States who came to our facility, and it was very interesting because he was very experienced about the symptoms and so on. So the answer is yes, and he has multiple sclerosis, and he had a good response.
Oh, great. I was going to ask, hopefully he's doing well now. That's excellent. Okay, back to you, Nick.
A lot of people who come from the UK especially worry about the aftercare, and neurological, so I can't even speak, have said that rituximab follow-ups is still needed. So do we still need to have a rituximab follow-up maybe in 5 years or something like that?
Well, initially, when we started this program, we recommended patients to go ahead with rituximab every 2 months for 1 year. But then we did an interim analysis of our results, and we were able to prove that by doing that, the relapse rate was not diminished. So we stopped doing that. What we did is that we increased the amount of rituximab delivered at the end of the transplant. And what we do is that we are suggesting rituximab, low doses, specifically 100 milligrams, every 2 months during 1 year for patients who experience a relapse. For patients which have not relapsed, we do not recommend rituximab. This information about this interim analysis has already been published in peer-reviewed journals.
Okay, over to Laura, I think.
Thank you. So this question is about vaccination after HSCT, and it's kind of in 3 parts. So the first question is, what are the chances of reactivating MS with a vaccination or any other trigger that might occur? Second part is the COVID vaccine different? And third part is, what should people do post-HSCT in terms of considering whether or not to have vaccinations of any nature, whether they are revaccination of childhood vaccinations or new vaccinations such as COVID?
Yes, the reactivation of multiple sclerosis by using any vaccine is a possibility. The chances are very low, less than 10%. Mm-hmm. And what we recommend is that since the transplant itself wipes out previous immunity, we recommend the patients to have a full immunization schedule 4 months after the transplant. The reason to this is that the effect of rituximab, which we deliver at the end of the transplant, lasts for 3 to 4 months. So it has to be cleared prior to giving the transplant, the patient the transplant, the vaccines. So we recommend a full vaccination schedule, including COVID-19, 4 months after having the transplant. And obviously, this has to be done back in their countries.
Yeah. Thank you very much.
While the rituximab is still in your system, you should have that.
Yes, the rituximab remains in your system for 3 to 4 months after you are given it. This being the reason why the vaccination has to be after 4 months.
Okay, with you. Just because that's something that I'm going to be doing soon anyway. Is it me?
I think, did you have a little more of that question to ask, Laura? Was there anything else attached?
I don't think so. I mean, we have heard some anecdotal evidence through our patients, our own patients that are part of our forum, that they've had their immunization, is it titers or titers, checked after a certain period of time, maybe 6 months, a year, to be told that they have lost some of their immunizations. But then at 2 years, these lost immunizations have suddenly reappeared. Is that possible?
The titles of antibodies against various viruses are not up to now the criteria to decide if patients have to be revaccinated.
Okay.
So what we recommend is that all patients, irrespective of the titers that they have, are to be revaccinated 4 months after.
Okay. Thank you very much for clarifying that. And I think, yes, I'm happy now to pass over to Alison.
Okay, this question is really in relation to the MRIs that are carried out, because we've had a number of instances where patients have been told in the UK that they don't have any active lesions which would help them to meet the criteria in the UK, and so they end up going overseas, and when they get overseas they have an MRI that suddenly shows up a lot of activity. Now, we spoke to one neurologist who told us that the number of lesions and then they're showing up in an MRI can be influenced by the length of time between the administering of the gadolinium and then actually doing the MRI. So he said if you wait instead of 10 minutes, if you wait half an hour, then we see a lot more lesions. But also we wondered if the strength of the MRI machines overseas are stronger in some way. I think that they're T4 MRI machines that are mostly used in the UK, I think. So what can you tell us about that, Dr. Ruiz?
Well, obviously the type of machine that you use to assess the presence of lesions is variable from one place to the other. I am not aware of details about the timing of administration of the gadolinium and so on, but honestly, I do not feel that this may explain why some patients do have lesions and others not. Probably it's the sensitivity of the machines. As you know, as time goes by, the sensitivity of all these machines increases substantially, and if you use very new equipment, your chances of picking up lesions that were not detected by old machines can be entertained. So I think it depends on the method more than on the timing of the gadolinium administration and so on. But I am not an expert in this X-ray imaging or imaging procedures.
Okay, it would be really interesting if you can find out and we can let people know what is the strength of the machines that you're using and how do they compare to what's being used in the UK, because I think people would find that extremely interesting to know. Okay, back to Nick.
This is actually a question I was interested in. So I heard that women get MS more, multiple sclerosis more, and men don't have it as often, but men progress faster. Do you have any knowledge of this? Is this a true fact?
In our experience, 66% of the patients with MS that we have grafted are female and 34% are male. So about 2/3 of them are female. We are in the process of analyzing the results, trying to identify factors in which explain why some patients do progress more than others. And up to now, we have not found that gender is a significant variable.
Interesting.
Okay, we've got some more technical medical questions that somebody has asked us to ask you, but we've had 2 more questions that have come in today, just sort of added on, if that's okay. So there was one lady who is looking to have HSCT, and she wants to know a little bit more about the washout period. And she says particularly treatments like cladribine, Mavenclad. She says that she's aware that can stay in your system for quite a long time. And can this affect the treatment or the recovery? So yeah, anything you can tell us about that?
The amount of cyclophosphamide that we are currently employing is 200 milligrams per kilo. This amount may be related to infertility, but the chances of having infertility as a result of the cyclophosphamide are very low. There are some other toxicities of the cyclophosphamide, such as cardiac toxicity, renal toxicity, and bone marrow toxicity. By dividing the doses of cyclophosphamide in 2 blocks apart, we have been able to show and to publish also in peer-reviewed journals that the toxicity to the heart, to the kidney, and to the bone marrow is substantially diminished if you deliver the cyclophosphamide the way we do it. So we honestly feel that we have been able to cut down the toxicity of the cyclophosphamide by changing a little bit the way it is delivered in some other part of the world.
Okay, Dr. Ruiz, I think you're getting ahead of us because you've got the list of questions there as well. We will ask you, and this is an extra one that's not on your list. So the question that Dr. Ruiz has just answered for us is the next one on the list that we've got, but we have an extra 2 questions. I'm just ask those at the very end. So the question that Dr. Ruiz was responding to then was that a lot of people wish to avoid cyclophosphamide due to infertility and cancer risks. And so this is what Dr. Ruiz has been telling us about those risks and so on. So I will come back to the extra 2 questions that we've got at the very end. But yeah, I'm going to hand over to Nick for the next one. And then Laura, if you want to ask the next one after that.
Yep.
How pleased are you, Laura, that you didn't have to pronounce all those
Quite
words?
pleased, because I pronounce cyclo. Yeah.
Have to do that. And to add on to that, Dr. Ruiz, I just had a question for you. If you're, let's say, 41, my age, and you have this treatment done, will it put me into menopause? Because I feel like I might be going through menopause. It doesn't bother me. I've got 2 children, but I just wondered.
I'm very interested in this question too, being a woman of menopausal age and very definitely in menopause. I was in peri before I went for HSCT, and I'm very definitely in menopause now, 2.5 years post.
Right, okay. What do you think?
The delivery of cyclophosphamide can induce an early menopause. That is possible. The amount of cyclophosphamide that we employ is not very well related as higher amounts along longer period of times, but there is that possibility.
Okay. Just so I know why I'm sweating so much, and just so my husband knows why I might go a little bit crazy for him. Now, my question, bear with me because I have a few long medical words I have to say. What does Dr. Ruiz think about using proteasome? Am I getting that right, Alison?
I think
Proteasome inhibitors.
Yes, like Rosenby.
Bortezomib.
There, see, I love it. I don't even have to say it. In order to kill memory B cells. What do you think about that?
That's an interesting approach. Bortezomib is used very frequently in patients with multiple myeloma, which is a B-cell malignancy. And what can I tell you is that there's not very many experience all over the world using bortezomib for patients with multiple sclerosis, but it's an interesting area to explore, yes.
Okay.
Alison, over to you.
Okay.
I'm taking this one, I think.
Oh, sorry, Laura.
That's okay. No, don't worry. So we have been told that some people develop a new autoimmune disease after their immune system rebounds from rituximab. And apparently there are plenty of publications on PubMed about this. The Mayo Clinic neuroimmunology partly attributes this rebound effect to BAFF, so B cell activating factor. The killing of regulatory B and T cells, Breg and Treg, may also contribute to this. And this statement from a medical professional, I know of a patient who developed debilitating pancreatitis after HSCT. So, Dr. Ruiz, what are your thoughts on these rebound effects?
Well, any treatment that somehow changes the immune response of a person is related to the development of another autoimmune disease or even malignancy. This is malignancies after killing or somehow changing the immune system of a person are usually very aggressive, and the most frequent of them is B-cell lymphomas. This can happen. In our experience, it has not happened in any patient, but I have to tell you that we still need more time to assess this, because usually this is a long long-term effect. I have to say also that all treatments aimed for different type of diseases are endowed with secondary effects. So what we have to do is to try to cut down the risk of developing these malignancies, this being the reason of delivering the cyclophosphamide that way, and also of choosing rituximab, which most likely on the long term is endowed with less toxicity than ATG, for example.
Mm-hmm. I have to say I am very personally interested in that question because being 2.5 years post, I'm currently under investigation for rheumatoid arthritis. So I was very interested to understand whether it is a real concern that this can happen to patients. And I think if Alison, if you're okay, I will ask the next question as well, because I think the two kind of dovetail quite nicely.
Together.
So if that's okay. So do you, Dr. Ruiz, perform HSCT only for MS, or do you also do it for other diseases, such as other autoimmune diseases? Apparently, Dr. Burt has done it for 3 patients with autoimmune, autonomic, I can't read this one, ganglionopathy, as well as other autoimmune neurological conditions such as myasthenia gravis, etc., with mixed results. For instance, the first AAG teenage patient got better, the second there was no change, and the third actually got worse and turned progressive. So what are your thoughts on that statement?
We have, in addition to multiple sclerosis, we have done patients with CIDP, in which we have got relatively good results. And we have also done, I guess, 2 or 3 patients with systemic scleroderma, systemic sclerosis, which is an autoimmune condition that is very debilitating. The results in systemic sclerosis are not as good as in multiple sclerosis, but it can be done. We have also done 1 patient with systemic lupus erythematosus, and as far as I recall, we have not done any patient with rheumatoid arthritis. The procedure has also been shown to be useful in Crohn's disease. As you know, there are some forms of Crohn's disease which are very aggressive, and the procedure can work on them, but we have not done patients with Crohn's disease. The stiff person syndrome is another indication for HSCT. We have not done anyone in Puebla, but one of them was transplanted in Monterrey, and he had a good response.
Fantastic. Thank you very much. I think that is all of my questions.
You've just got 2 extra questions.
Oh, yes. Sorry, carry on.
2 additional ones that just came in today. One of them is from a lady who is hoping to have HSCT soon. And she wants to know, is there, does a treatment like cladribine, Mavenclad, that can stay in your system for a long time? She knows about the washout period and so on, but can they affect the treatment or the recovery in any way?
Yes, this is the reason why we ask the patients to be on a washout period of 3 months prior to the transplant. However, we are in the process of analyzing if the use of previous drugs is related somehow to the response to the transplant. And it seems that we are finding something interesting along that line. So patients that do have prior treatments probably do worse than those that have not had prior treatments. But as I say, we have not fully finished this analysis, and we have not published the results, but we are in the process of making this analysis.
Very interesting. And the last question is one that came up twice from 2 different people who were told by their neurologists that when you go to Mexico, you will come back and your bloods will be completely normal. There will be nothing any different because they're not doing anything to you. Have you ever had a patient whose bloods have been completely normal at the end of the process?
Well, it depends on what you look for. If you look for the granulocytes and white cell count and platelet count and hemoglobin levels, yes, they are normal. As a matter of fact, it's a requisite for us to send back the patients to their countries with that number of tests already normal. But if you look at the number of T cells or B cells after the delivery of the cyclophosphamide and the rituximab, then you will be able to find out that the number of B cells goes up to 0%, and that lasts for 3 to 4 months. So it depends on what you look for. If you look for hair, yes, they lose hair. They go back without hair. Of course, so it depends on what you look for, what you end up doing. But as I say, in order to jump into a plane and go back to their places, they have to have a normal granulocyte count and a number of white blood cell count.
Okay, that's really helpful.
They also give you all your bloods to take away with you, a record of every blood test that you've had from day dot. So in my file, I have probably 4 or 5 different things that say all of my blood results so that I can show them to my doctors when I get home, and they're all different.
Yeah, of course, of course. So that was our very last question. So I think it just remains for us to thank you so very, very much for doing this podcast with us, because I think it's going to help a lot of people once their doctors see this and hear it from the horse's mouth. I also want to thank Lee, who has the MS Warrior podcast, who's been so patient with us with all the technology going wrong and so on. Hopefully Lee will be sharing this on his platform as well, even sort of in a slightly different format. Thank you so much, Lee. He sat there and been very quiet because he wanted us to divide the questions up, and he's doing the technical editing side of things for us. And this will also be being shared on Nick's platforms as well, on Instagram, on Nick's New Beginnings. So we're really, really excited that this is going to reach a lot of people. It will, of course, go on our website and all of our social media as well. So thank you so much for your time tonight and your patience with all the technical problems that we had at the beginning.
Probably you would like to make available all the papers that we have published on our experience grafting patients with multiple sclerosis. Initially, the feasibility study, then the safety study, then the efficacy study, and then the description of the largest experience in a single center of 1,000 patients with HSCT. Those papers are available. They have been widely quoted in the literature, and anybody can look at them. Also, it is available, the website in the www.clinicaltrials.gov from the National Institutes of Health in the United States, and anybody can access that information to find out details of our protocol, results of our protocol, and so on.
Excellent. We will make a transcript of this podcast as well, because I think it's going to be really useful for people to home in on the things that are of particular interest to them, because so much information here. But we will also gather together all the links that you're talking about, and we'll double check that we've got everything so that it's all there. But yeah, fantastic amount of information, and so nice to be able to address all of these things finally, because it's just been crazy how long it's been going on. So thank you again for everything. So Laura,
thank you, everybody.
Thank you.
Keep well, safe, healthy, and faithful.
Thank you. And you. Bye-bye.